Ngizovula phela la bazongizwa.
Good afternoon. Good afternoon, honorable members. You are logged into a portfolio committee for health meeting that is scheduled
Recording
to
in
start now.
progress.
We'd like to welcome you and thank you for logging in. Can we start our meeting by just observing a moment of silence and meditation? Thank you very much, honorable members. Welcome. And thanks to those who have logged in also to participate in this presentation. May I request that the first presenter, while we are doing the preliminaries, is already given the sharing rights. That would be, I think, a presentation by the Professor Harper. So whoever is the first presenter can be given sharing rights while we do the preliminaries. Ms. Jalamba, can you show and indicate firstly who are members who are logged in?
Good afternoon and thank you, Chair. Present is Dr. Dlomo, Ms. Shabangu, Ms. Kumalo, Ms. Clark, Dr. Leroux, Mr. Mutubatsi, Ms. Chirwambu Ngose, Dr. Litlape. I've received an apology from Mr. Van Staden. Thank you, Chair.
Thank you very much. Welcome, members. You are logged in and official. Yes, Honorable Mare, you are in.
I'm also here, yes.
We recognize you, Honorable Mare. You will also be marked present like all of us in this meeting. Thank you very much. Ms. Machalamba, can you then reflect the agenda? I would wish that the members start the agenda as shown to all of us. Like this presenter, I'm going to start giving a presentation. The first one is going to be done by the Professor Harper. Yes, it starts at about 3:05 for 30 minutes. At 25 to 4, we will start with our questions. If honorable members prefer to use their slot 15:35 up to 16:10, 16:05 for only asking questions, that's all that we have. Because we would then not be able to encroach too much as we have done into other spaces. So honorable members are requested to be very brisk and ask focused questions, maybe 2 or 3, so that they can then present their responses. All presenters, they will not then be able to extend beyond what is indicated in the slot, as we do have quite a lot of other presenters to then still come in. We have been a bit lenient. Now we'll stick to the time. So please, honorable members, look at that and then indicate and just check that you can't ask 10 questions, because all of us 8 here asking 10 questions will need this. If the presenter is unable to answer all questions, then the presenter will send those follow-up questions in a written form so that we can stick to the agenda. I hope that members will understand and appreciate that. May I therefore invite the first presenter, who's Professor Harper, who's going to be presenting. Professor Harper, I hope you do have the sharing rights by now, and you will be presenting for
you
not
very
more than 30 minutes.
kindly. I hope you can hear me.
Yeah, I'm still introducing you. You will have to do within your 30 minutes. And if you are actually beyond 30 minutes, you will have to add on that when you actually respond. Your response will be based on what members would have. After a presentation, members are going to ask and interact with you. Please take pen and paper to interact with them and then reply accordingly. But we will be able to mark you down on the time and we'll stick to the time as indicated. Thank you very much. Your time starts now, Professor Harper.
Thank you. And you very kindly agreed to change my slides for me because I had to change computers, I'm afraid. So thank you very much indeed. Honourable members, I'm Peter Harper, and I would like to begin by expressing my deep gratitude for the invitation to speak to you. It's a real privilege to contribute to your conversation, and it's a very important conversation indeed, one that has the potential to change the course of public health here in South Africa, not through abstract policy, but through something far more important, which is people's lives. Next slide. So I come before you not as a politician or as an advocate, but as a physician, and in fact, an oncologist, and indeed a lung cancer oncologist, a cancer specialist who has spent over 4 decades sitting with patients and their families through the hardest moments of their life. And I speak today not just from what I know, but from what I have witnessed in hospital rooms and waiting rooms, in triumph and in heartbreak. Cancer, as you know, is not just a disease of the body, it's a human experience. It challenges not only our biology, but our dignity. It doesn't ask how much money you earn, what community you come from, or what you have contributed to society. It simply arrives, and when it does, it changes everything. Next slide. So here are my disclosures, and I want to be clear about it. I consult with both the pharmaceutical and the tobacco industry, but only on topics to improve health. My goal has always been to help people live healthier and longer lives, and to do that in my subject, we have to engage with all industries. Next slide. So when I look at South Africa and life here, I've seen remarkable strength in those facing cancer, but I've also seen something else. And it's the damage done not just by the disease itself, but by silence, the shame, and the stigma that surrounds it. And that, honourable members, is where I want to begin my story today. Next slide. So stigma hurts people, and stigma, blame, can be inadvertent. But you can imagine in a lung cancer clinic where 80% of the patients with lung cancer will be smokers or former smokers. And virtually all smokers we know will know that smoking causes cancer. So before they even come to you, they know that a habit that they have is probably responsible for why they are there. They don't need you then to put any blame on them. Stigma is one of the most destructive forces in healthcare, not because it leaves a mark on the body, but because it pushes people away from care. When a person believes their illness is their fault, they delay seeking help, they hide their symptoms, and sometimes they give up before they've even sought help. I've seen this time and time again, men who wait too long because they feel they deserve their cancer, women who fear what their families or communities might say, and patients who tried to quit smoking but returned to it quietly. They already feel guilty. They feel ashamed, they feel isolated, and they feel unsupported. Next slide. So, Chairman, you've asked about data that's published in South Africa, and I've tried to relate to that. The Mansour family, who live in South Africa, started the Resilience Project, and I was very privileged to write the foreword to that book, and captured this heartbreak with devastating clarity. Patients who hid their diagnosis or assumed they weren't worth the cost of treatment, or thought that disease was in some way their fault. That sense of shame is not theoretical. It keeps people from walking through the clinic door. But stigma doesn't stop with diagnosis. It follows people into and out of treatment and even into survivorship. And I was online with you a couple of days ago, and someone quoted this number. 64% of people who smoke at the time of their lung cancer diagnosis continue to smoke afterwards. And that's not a reflection of indifference, it's a reflection of complexity, of addiction, of stress, and of survival. Next slide. So, resilience from what? Smoking as a coping mechanism at the exact moment when a person is reeling from the shock of their cancer diagnosis, facing surgery, chemotherapy, uncertainty, and pain. We tell them that they have to give up the very thing they've turned to for decades to manage their stress, their fears, and their uncertainties. It's not an excuse, but it is the reality. For many, smoking is not just a habit, it's a coping mechanism. And when everything else in their life feels like it's falling apart, we're asking them to face it all without that coping mechanism that they've used. We're saying to them, their families are frightened for them, they may push hard, you have a cancer, you have to quit. Their clinicians who are focused on outcomes may express frustration. Why are you still smoking after everything we've done? The patients themselves feel the same conflict deeply. I've had survivors whisper to me, I'm still smoking, even though I know I shouldn't be. They tell me they would drive a couple of towns to buy the cigarettes, just so no one in the family or a neighbor would see. And that's what stigma does. It breaks down honesty, it erodes trust, and it replaces support with shame. Next slide. But here is the truth. Stigma, shame, and judgment are not a treatment. They do not help people quit. They do not build resilience, and they do not save lives. If we want patients to reduce their risk of cancer or after cancer, we have to support them through it. If we want them to quit, we have to give them tools. If they can't quit, we have to give them alternatives that are substantially less harmful than smoking, that are substantially less harmful than smoking. This is what harm reduction is. It's not a compromise. It offers patients a safer way to cope while they work towards quitting. It helps maintain their relationships with the families and their care providers, and it clearly says your health still matters, even if your path is not perfect. We cannot afford to let stigma undermine our efforts, not before diagnosis, not during treatment, nor after survival. If we do, we risk losing the very people we are trying to help. Next slide. So the science is clear. Let me now turn to the science. Because while stigma keeps people away from care, science is what helps us bring them back. And the science in this case is clear. When it comes to tobacco, smoking causes cancer. This harm, as you've heard many times, isn't caused by the nicotine. It's caused by all the chemicals, the carcinogens, that people expose themselves to when they light a cigarette. They burn it, they set it on fire. The tobacco burns and they inhale the smoke. When tobacco is burned, it releases a toxic mixture of more than 7,000 chemicals, many of which are known carcinogens. Again, you've heard the names: benzopyrenes, acrolein, tobacco-specific nitrosamines, and formaldehyde. These are the agents that damage the DNA, that cause the mutations. They suppress your immune response, and they drive the cancer. Yes, you're right, nicotine is addictive, but it is not the cause of cancer, and that distinction matters because it opens the door to a way to reduce the harm for someone who will not, and there is a great number of those who will not, as well as those who cannot quit. Next slide. So this slide is about bladder cancer. On the vertical axis is the relative risk. On the horizontal axis is the pack years of cigarette smoking. Clearly, the more pack years you have, the higher the risk of bladder cancer. And we've mentioned the cause of that. That is the excretion of acrolein, which comes from the smoke of a burned cigarette. As an oncologist, I've spent my career explaining what a dose-response curve means to my patients, to my students, and to policymakers. It's a principle as old as medicine itself. The more exposure to a harmful agent, the greater the risk. If you smoke 1 cigarette a day, your risk is lower than if you smoke 20 cigarettes a day. If you smoke for 1 week, your exposure is less than if you smoked for 20 years. 10 minutes in the sun is not the same as 10 hours. Whether it's tobacco, alcohol, ultraviolet exposure, if you switch your behavior, you reduce your carcinogen exposure, your risk will be lower. This is not theory. We actually have real-world examples. Next slide. Apologize. Next slide. So this is a complex slide, but it's also a simple slide. So in Sweden, and again, you've heard of this before, you have snus, a smokeless oral tobacco product that has been widely used by men for decades. It contains tobacco, it contains nicotine, but does not expose people to the high levels of carcinogens in smoke, and therefore dramatically lowers the risk of smoking-related cancers. In Europe, Swedish men, if you look at the right panel, have the lowest rate of daily smoking, around 5%, and the lowest lung cancer mortality rates. So that right-hand panel says that this is male lung cancer mortality. The tall bar is the average in the EU. The short bar is the incidence per 100,000 males in Sweden. Now, it is half the risk of the average EU country. It is 1/4 of the risk of the worst countries, of Hungary and countries like that still smoke very heavily. It's 1/4 of their risk. You might think this is not a tobacco issue, perhaps something specific to Swedish genetics or diet. It isn't. The fact is that women did not make the switch away from cigarettes as soon as the men. And although their decline in smoking is starting to accelerate, their lung cancer mortality rate is very similar to that of the EU. So if we now go to the main part of the chart, the blue line is men's snus use. And as you can see, even before 2004, there was a much higher snus use than there was cigarette smoking use. The green line is male smoking. At that point, it was very nearly 15% of the population. Now it is 5% of the population. The yellow line is women smoking, and you can see it's the only nation in Europe, indeed one of the very few nations in the world, if not the only nation in the world, where women smoked more than men. The women's yellow line is above the green line. If you then look at the red line, that is snus use. So suddenly you're seeing a rise in snus use, and we will now see a fall in the amount and the quantity of lung cancers in women. Next slide. So what happened in the UK was different. We, like the rest of the EU, we do not allow snus. Sweden had a buyout in its clause when it joined the EU, and was allowed to keep snus. We do not have snus. So in the in the UK, we had to look at something different. Public health authorities reviewed the evidence on e-cigarettes, vaping, and while concluding that they're not risk-free, they also state that vaping is at least 95% less harmful than smoking. As a result, they've embraced e-cigarettes as a harm reduction approach and even integrated into some of their smoking cessation problems. And the UK now has some of the lowest smoking rates it's ever recorded. This is harm reduction in practice, helping people move from a high risk to a lower risk behavior, guided by science. And yet many still believe that all nicotine use is equally dangerous. I will often hear it. A vape is just as bad as a cigarette. Switching to another product doesn't make a difference. That belief is not only incorrect, it costs lives. Next slide. So harm reduction is not a new idea. It's already embedded in public health strategies, from sexual health to drug use and to road safety. Here in South Africa, you championed harm reduction in your fight against HIV and AIDS, and you saved millions of lives. What's new today is that we have to start applying this approach in areas beyond acute disease. We need to impact now on the root drivers of chronic disease, and that will include smoking. And we have the science and the tools that allow us to apply this type of thinking to smoking. Let's do it. Just as we would never say that drinking a glass of wine is as dangerous as driving on drink, we would never say that using condoms doesn't reduce the risk of HIV just because it doesn't eliminate the risk altogether. We should not pretend that all tobacco products carry the same risk when science tells us otherwise. E-cigarettes, heated tobacco products, oral nicotine options offer smokers a way to reduce their risk, even if they cannot quit completely and cannot do so today. So what Sweden has done is it's given us a real world example of what can happen if you switch away from smoked tobacco. Next slide. I apologize, I've got a virus. In South Africa, this matters more than ever. Because despite decades of tobacco control, smoking rates have stalled, as shown in this line. The most recent global adult tobacco survey, the GATS, shows minimal decline in prevalence. And those who continue to smoke are disproportionately from underserved communities. And in a way, I wanted to address the majority of my talk about underserved communities. It's all very well speaking to each other, doctors, dentists, members of parliament. We can read the evidence, we deal with the evidence all our lives. We change our habits. But that's not what happens countrywide. The same people are more likely to face barriers to care and more likely to face stigma if they don't succeed are those people who continue to smoke. To tell those people they must either quit or be left behind is not public health. It's moral posturing and it's ineffective. The goal cannot be to punish those who struggle. It is to protect them. That is what we're there for. And that is what harm reduction does. In the context of cancer prevention, it's one of the most powerful tools we have. Now, in South Africa, you have as yet a young population who are not as yet seeing the impact of the habits of today on the diseases which will be of the later decades. Next slide. So you need to build a framework. You have a choice. It does not have to be about products. It does not have to be about policy, but should instead be about how South Africa approaches public health going forward. You've had many, many discussions on the science. I've sat in on 3 days and the science is there and you've heard it. We know that smoking is still a very relevant issue in South Africa. We know that stigma harms and that harm reduction can help. The next step is to build a framework that reflects what we know and we serve. That framework must be both scientific and compassionate. It must start by acknowledging that not all products are equally harmful and not all people are equally positioned to quit. The simple truth should be the foundation of this law. Next slide. So we've got to protect youth. Yes, you must protect young people. There's no place for youth-targeted marketing, flavors, packaging, or easy access to products designed for adult smokers. But in doing that, you must not lose sight of the current 11 million South Africans who already smoke, and inevitably those who will start. They deserve options that can reduce their risk, and this is at the heart of a risk-proportionate regulatory approach, one that regulates according to relative risk, not political comfort, one that allows adults to access less harmful alternatives while ensuring strong safeguards for those who should not use them. Next slide. This has been done in Japan. Heated tobacco products are tightly regulated, widely used by adult smokers. Cigarette sales have dropped by more than 50% in 10 years. There's been no corresponding increase in youth uptake. In the UK, vaping products are regulated, but they're also recommended by public health services. They have been effective not only in reducing smoking rates, but in reaching hard-to-reach people and people who've tried to quit before and failed. This is the model that South Africa can build upon. Science-based framework tailored to your context, guided by your values, and informed by the evidence. Now, again, Chairman, I heard you previously, you said, let us leapfrog, let us learn from what others have done. You've done it as well. You did it and led the world with HIV and your response. Next slide. I recently wrote a book chapter on harm reduction, from principle to practice, where I say it is as simply and clearly as I can. Harm reduction is not a weakness. It is courage. It is the recognition that saving lives does not require ideal solutions. It requires realistic steps, realistic progress to make the way forward. This bill is an opportunity to write some of those steps into law. Next slide. So, what do we have to do? We cannot have blanket bans, but we cannot have a free-for-all. We cannot have a solution focused on perfection. It will not happen. You need a real solution. You have to protect children from initiation. You have to help adult smokers find safer alternatives. You require transparency and product standards which have to be imposed. And it puts truth, not fear, at the center of communication. Next slide. So you've heard how stigma keeps people from care, both during and even after cancer. You've seen the science that tells us not all tobacco products carry the same risk. And you've heard how harm reduction is not a compromise. It's a chance to meet people where they are and to save lives. We have the opportunity to act, to craft a law that protects young people, supports adults who still smoke, and reflects both the evidence and the empathy that public health demands. Next slide. This is the penultimate slide. Cancer care is changing. Cancer care and generally public health is moving in this direction around the world. The most effective systems are those that integrate new tools without abandoning the people who need them most. It's a challenge, there's no doubt about that, but it's also an opportunity to lead with clarity, to legislate with humanity, and to show the public that health can be attained, but it can be attained by being both rigorous and kind. My final slide, next slide, is based on some of the stories in the Resilience book, which is a South African book. You can see from the ages of these patients that they were breast cancer patients, not lung cancer patients. But the story is the same. I'll read you just the top left one. As African people, we need to educate ourselves. We need to understand that cancer is everyone's disease. The more we open our minds and hearts to what is happening, the more we will conquer cancer. And then the one below that, it has taken 2 years for me to be able to say to myself, it's not anything you've done. It's just one of those things that happen. And that really is why I'm before you today. I'm before you today to give what I would call a real world oncologist view. It's to say my job is to see fewer patients with cancer because there are fewer patients with cancer. That you can do. You've already seen that the smoking-related cancers in Sweden, who could believe it, can be halved compared to the rest of the EU. This is pretty massive change and something we should be not only interested in, but we should think about, perhaps legislate towards. Thank you.
Prof, you
I do
kept to your
apologize.
time, Prof. You kept to your time, Prof. Thank you very much. You did.
Lots of questions.
We are learning that this bill is probably strong on avoiding initiation, especially the young ones.
Yes.
But the bill is not very strong on assisting me and my cousin and my brother, who is already a smoker, and to be offered something less than that. Okay. Let us hear honorable members interacting with you, Prof. Honorable members, we have this discussion up to 4, both the questions that you are going to ask, including the responses. At 4, we will have to stop the Prof and move on to another one. So be conservative with your time. I now recognize hands, starting with Honorable Khumalo, followed by number 2, Honorable Clark, number 3, Honorable Dr. Leroux, number 4, Honorable Mutubate, number 5, Honorable Sinne, number 6, Honorable Chirwampungose, number 7, Honorable Eko, number 8, Honorable Shabangu, and number 9, Honorable Mare. Then the last, there's another 10, Honorable Dr. Letlape. 10 hands. If all of you were to take 10 questions, then there will be some of us who won't even ask questions, but will stop before the 4. So let us start. You know your numbers now, honorable members. Start. The first one is Honorable Khumalo. Thank you.
Thank you very much, Chairperson. Greetings to all honorable members that are in the platform and Dr. Peter Harper. Let me take this opportunity, Chair, to welcome the presentation as presented to our good selves. But I'm just having some few things that I want to get clarity on. On the presentation, Dr. Harper, you have claimed that the demand for cigarettes reduced by 56% from 82.1 packs per capita in 2010 to 36.2 packs per capita in 2022. That is a decline in cigarette sales. Then I would have also appreciated, Doctor, you acknowledging that in the same Japan that you have mentioned, the heated tobacco products use among the youth has been increasing. Also, you fail to disclose that Japan has banned all e-cigarettes containing nicotine. Do you also recommend we ban these products in South Africa? Because you can't pick and choose policies just because it suits you, it suits your narrative. That would be my input, Chairperson. Thank you.
Thank you, Chairperson, and thank you very much for the presentation, Professor Harper. I have flu, I'm not a smoker, so I'm just adding that my voice is getting better though. There are some studies that found long-term use of electronic cigarettes or vaping products can impair the function of the body's blood vessels, increasing the risk for cardiovascular disease. What is your opinion on this, and have you considered this for your presentation to us? Then do you consider such studies in your role as harm reduction consultant to tobacco companies? And how would you suggest vaping and non-combustible products be regulated to make them safer? Are tobacco companies not simply spinning research information to exploit a new market and keep their revenue streams going, or while being fully aware of the harm of products that they've been proven to do in the past with cigarettes? I thank you.
Thank you, Chair, and thank you, Professor Harper, for your presentation. I just had a couple of questions. I've heard the figure of 95% harm reduction mentioned quite often, and so I just would be interested to know how that was worked out. So if we're talking about vaping products compared to and other nicotine products compared to cigarettes. So I know that they're different models, but that's the one thing I hope that you might know the research on that specific topic. And then the second question I have was just around the British experience. I know that you've mentioned that Public Health in the UK have recommended that people move from vaping to smoking. I mean, from smoking to vaping. And I know that there was also a time, I'm not sure if it's still happening, where vapes were given to smoking pregnant women as a harm reduction strategy. What are the research findings on that specific that in health intervention? I don't know if you have that data and whether there was some evidence of reduction in harm in that specific instance. Thank you very much. And yeah, thank you for your perspective, specifically from a stigma perspective, which I haven't heard before. Thank you.
Well, thanks very much, Chair, and thanks, Prof, for the presentation. What, in your view, led to the stalling? I saw at some point you indicated that there was some stalling in some years. If you can share with the committee, and you also indicate that not all products cause harm Can you elaborate on that with the current hype that is there, that harm is harm? Can you elaborate on that because some of us has different views around that particular issue? On branding, would you agree with me that plain packaging will hide criminals or culprits of illicit production? And if we are to continue with branding, we will be able to have law enforcement agencies being able to identify who is who in the market and be able to act accordingly. Unlike when we have plain packaging, which might hide the culprits. Thanks very much.
Ngiyabonga Sihlalo. Greetings, colleagues, and Professor Harper, and to the staff members, Kamala Munali Chirampungose, deployed by the EFF. Prof, I just have a few questions here, 3 in total. I see the sentiments you're sharing on the issue of nicotine and it being the primary substance that causes addiction. I wonder if the proposition of the professor is that we should move towards the direction of banning nicotine. That's number 1. And number 2, we also appreciate the highlighting of the issue of shame as being a prevalent tool in processes of rehabilitation and issues of sickness and chronic illnesses and stuff like that. I'm wondering, Professor, maybe you will advise on what the proposal therefore is of shifting society and policymaking from shame-infused methods, and what then would become the alternative method or modus operandi that is rooted in healthcare, as opposed to shame-infused practices. If you can give tangible examples, I think that will also assist the committee as well. And then lastly, Professor, I'm very wary of the proposition of saying vaping is a safer or less harm alternative as opposed to smoking, right? And I say this because there was a time when there was no assumption that nicotine and tobacco were harmful products. I mean, at some point in this lifetime, there used to be adverts of pregnant women smoking, and it was considered a safe thing. And I think we don't have the liberty of enough time and enough research, even if it's there and it's conflicting in some instances, in some countries, in some academic journals. Don't you think it's perhaps too premature to consider vaping a less harm alternative with the current issues that I'm currently raising on why it would be a premature decision to do so? Thank you so much, Professor.
Thank you, Chairperson. And let me also welcome the presentation. Professor, could opposing youth protection measures be perceived as prioritizing product sales over genuine public health outcomes? That's my first question to you. And the second one on slide 9, on the science is clear. If you say nicotine is not responsible for the harmful effects of smoking, that's very worrying because that is not true, honestly. What about concrete evidence on its cardiovascular effects, blood pressure impacts? And why will this Parliament of the Republic of South Africa not be concerned about nicotine if it is linked to the burden of diseases in our country? Your harm reduction theory fails to address that. Lastly, how do you account for research showing nicotine's potential effects on adolescent brain development and addiction pathways? And how do you reconcile industry funding with potential bias in interpreting nicotine safety data? Thank you, Chair.
Thank you, Chairperson. I think it's my turn. Go speaking. Good afternoon to everyone connected to the platform, starting from you, Chairperson. Chairperson, I join my colleagues in welcoming the presentation. I have few questions to Professor, but I will start with a comment that says, I understand Prof as someone who thinks that the bill proposes a ban in smoking, which is not the case. I think there's always a common word, harm reduction, which says the bill does not in any case suggest a ban. It's about saving people. It's about people's health. Quitting may be the end result, but it is left to be voluntary, the quitting part of it. I will be leaving the ones that refer to cancer. We still in the agenda have the Cancer Association. I won't dwell much on that, but the fact that every packet of cigarette has a note that says smoking causes cancer, which serves as creating awareness to those that are addicted to smoking. But let me reserve that question. Coming closer to what has been presented to us, I think Prof is supposed to be joining those that are advocating for what has worked well in the UK, because it is also contained in this bill. I think I would be the one inviting Prof to be advocating for what he has understood as working well in the UK. Also, I am interested in understanding if there is any data that he can provide, because in the presentation, I am made to believe that by the year 2018 up to 2022, as it reflects on the diagrams, that there was a decline, but it became flat from 2018 up to 2022. Interested in understanding if there is any data regarding vaping in South Africa during the same period, 2018 to 2022. I'm asking that because some local data suggests that vaping is now increasing as well as smoking, but I would like to get his view regarding that. And also, what would the professor suggest, given the fact that in South Africa, the numbers are high on youth population? Unlike the countries that he has referred us to, what would he suggest? Also, wanting to have his opinion on the bill in its current form. I think I needed to get those clarities and also having those suggestions. Thank you very much, Chair.
Okay. Honorable Teko, we will request next time you hit it quite faster.
I will, Chair. Thank you.
Thank you, Chairperson. And I would like to greet all my colleagues and thank you for the presentation. I just have one question. The Prof was speaking about cancer, and lung cancer is usually associated with smoking. But I just want to know, because I know of a person that passed away of lung cancer that never smoked in her life. So my question is, many years ago, they were saying that passive smoking is more harmful than the person that is smoking. So I want to know, what is the Prof's view about that? And then also I need to understand is that Is vaping the same thing? When you're a passive smoker for vaping, you can inhale those vapes. Can that also cause cancer? I just need to understand the two of them, because they used to say passive smoking is much more dangerous than the smoking himself. So I want to know this vaping, is that the same case where a person that is not smoking sitting next to a person that is smoking, can that also be harmful and then cause cancer at the end of the day? Thank you, Chairperson.
All members have asked now.
No, it's
No,
me now. It's
okay.
me. Thank you,
Yeah,
Chairperson. Let me,
I suspected that Honorable Mare, when she
jump
wants to
me.
start, she starts. She has jumped Honorable Shabangu, and she has jumped Honorable Dr. Letlape. Any other person who has been jumped? Just those two. Okay. Yeah, in my note, I noticed the Honorable Mare to be the last one, but then there are these two. Come in, Honorable Shabangu will be followed by Dr. Letlape. Thank you.
Thank you, Chair. Let me write on the same greetings and appreciation of the presentation. The presentation by Doc here it's stated that the goal is to protect the youth while allowing adult access. I want the doctor maybe to clarify this committee, portfolio committee, on where is the actual conflict, because the proposed bill, it's the screen of the prof is disturbing, but anyway, the proposed bill is regulating flavors and stop youth targeting market. Also restrict access, allowing adult access to smoking. So where is the actual conflict from the proposed bill and your goal? Maybe you can clarify on that. And my next question is that you indicated that smoking is a way of managing stress, fear, loss and control, loss of control. In South Africa, have you ever seen any initiative by the suppliers of these products addressing youth mental health issues or stress issues, youth uptake, and youth targeting marketing? Or are you advocating for a status quo? Thank you, Chairperson.
Thank you, Chair. Khosi Letlape, thank you for the presentation. My question is to elicit comments from you about what might inform the policy inconsistency to start with. The fact that you've explained how Sweden has used snus and other countries like Norway have joined in the last decade or two, how they got an exemption when they joined the EU. Then you have the fact that snus is not allowed in Britain, and they've accepted vaping into their system. You go to Japan, heat not ban is allowed. Vaping is not allowed. And there's been the Global Health Report that spoke about the reduced incidence of tobacco-related diseases in Sweden. And in the middle of all these issues of inconsistency is the WHO, which is the one that has proposed the ban of snus initially. And they're the ones that are promoting the policy inconsistencies. I mean, when the Prime Minister or Health Minister of India banned vaping, he was given an acknowledgement and a prize by the WHO. And that goes to some of the questions that have been raised by colleagues. Why do we have this policy inconsistency? Then the next direct question is, in relation to what has been shown scientifically, how Sweden has succeeded and the reduction of tobacco-related diseases, and the reduction of tobacco smoke in Sweden, which are the aims of the FCTC. Why is the WHO not accepting that what Sweden has done has proven that the main problem is combustion? And what is the accountability of those that have clubbed non-combustibles with combustibles and missing out on the public health opportunity of saving lives, as evidenced by the Global Health Report of 2023, where it shows that Sweden has saved thousands and thousands of lives. And if the rest of Europe had adopted that policy, thousands and thousands of lives would have been saved. And lives would have been improved, health would have been improved, the downside of smoking could have been reduced. That's all that I have, Chair. Thank you.
Professor Harper, you have received questions on members within the last 20 minutes. You only have 10 minutes to reply. There's WHO coming in late in the presentation in the day. You can leave it to them, some of the questions if you wish, but I will only restrict you to 10 minutes reply. Thank you very much.
Thank you so much. And the questions are very stimulating, and they will help me model my future talks. So let's try and put them together. So I truly believe that the science behind combustion versus non-combustion is sound. It has been independently monitored by the FDA in the United States in a smoke laboratory. They've checked all the facts. I think all of that we will accept as science, and we can check it, and I can send you all the relevant data. The vaping versus heat not burn versus nicotine pouches versus snus. To be honest, as long as, from my point of view, as long as you don't inhale what we used to crudely call tar, but what we now know is a mess of burnt leaf together with carcinogens, together with 7,000 odd chemicals. As long as you don't inhale that, to my mind, you're a lot better off than having combustion. In terms of whether something is 95% safe, less harmful, 98% less harmful, whatever the small differences are, I think we don't know, and we should accept that. But what we know is that it is significantly less harmful. And one of the most interesting, I thought, points addressed by the honourable members 2 days ago was this concept that pharmaceuticals, we put in the packet insert, there's not a single pharmaceutical that doesn't have some harms. And we just have to live with them, and we have to make sure that the benefits and the application of that drug is better. Now, where tobacco falls down is that this is part of a lifestyle choice. And a lot of this is wrapped up into a lot of other lifestyle choices too, be they obesity, be they lack of exercise, all the other things that we're getting wrong with fast foods and trans fats, and the whole of it is wrapped up into together. But of course, here you have nicotine and you have an addiction, but equally sugar with an addiction. And so we have to be very careful of both as medical doctors as well as legislators that we separate out what we're trying to do. And that's why I found it so good, the amount of discussions that you've had. Banning nicotine, should we ban nicotine? Well, yes, in many ways, but what are you going to do? Everybody finds their way to their particular weakness. So whether you drive your car too fast, whether you do A, B, or C. We legislate for seatbelts. We legislate for airbags. We legislate for crumple zones. We legislate for petrol versus electricity, for diesel versus petrol. All these things are vitally done. But what we have to accept is that people are going to find their way to what they want to find. And so as I go through all the questions, we should not be marketing to the youth. We must very carefully do that. We've already had a couple of days ago a very good discussion on flavors. Of course, even every cigarette is flavored in some way or another. The science of nicotine and brain development, I think we have to keep in mind, and there is no recommendation that anybody should start with vaping, but for sure, if they start with a cigarette, they're doing themselves just as much, if not more harm. So it's a relative risk, of course. Quitting is the end result. It's not the whole result. A less harmful way forward is something you may have to do. So in terms of the bill and where we're going, I think that any harm is harm is not appropriate and cannot be appropriate. The tobacco industry has to bear the burden of decades of misinformation, and it does bear that burden, and it has to acknowledge that burden. What has it come up with now? Well, it has come up with, I believe, scientific evidence that what it's proposing is significantly better than what we have. But would we be better off with none of it? Yes, we would. But you can't turn the clocks back that far. We also have a lot of pressure from nations which produce tobacco. You have tobacco farmers. You have to acknowledge that they have a cash crop. You have to think very carefully as nations what you're doing. And of course, part of that nicotine from the cash crop is going into these products. So why is WHO not accepting it all? I'm looking forward to hearing their thoughts. So I hope I've given an answer to very many questions. I'm happy to produce a written result for these to submit to the committee, which I think might be the best way of rounding them all up. Thank you.
Sorry, I pressed the wrong button. I'm back now on the platform. Can you hear me, Ms. Matalamba?
Yes, I can hear you, John.
Yeah. Professor Harper, we'll appreciate that you do send us, maybe start drafting it today. It was interesting listening to you. Because of time factor, you could not go point by point, but you highlighted an overview of your responses. Please do write to us a complete response on your questions. We appreciate that. Thank you very much. Okay. Ms. Machalamba, at this time now, you need to indicate to me who is next. Is it Professor? Not the professor, not.
The University of Pretoria, Chair.
Okay, University of Pretoria. I didn't know the name, but University of Pretoria. You have 30 minutes to make a presentation. You will also be handled like Professor Harper. If members ask and finish all your time for discussions, you'll have to be very short and concise on your responses. But, this is Professor Yusuf. Your time is now. Start, and 30 minutes will finish off at 4:30. Thank you.
Thank you, Chair, and thanks to the committee for the opportunity to share with you my presentation today in support. I must declare upfront in support of the bill. I am hoping that you can see my presentation.
Yes, we can. We do see your presentation. Thank you.
Thank you. So I'm the head of School of Health Systems and Public Health at University of Pretoria, and I'm also the director for the Africa Center for Tobacco Industry Monitoring and Policy Research, and also a member of the board of the National Council Against Smoking as the executive director. I also chair the Standing Health Committee at the Academy of Science of South Africa, and I must declare that I'm a member of the WHO Tobacco Products Regulation Study Group. As part of my declaration, I received no funding from tobacco or vaping industry. My research is funded through the National Research Foundation of South Africa and the Africa Capacity Building Foundation, which is an agency of the African Union. I've collaborated, and I've also received funding from Newton Funds in the UK and MRC South Africa, as well as working with the Human Science Research Council for the last 20 years, doing surveys in South Africa. So my interest is to share with you some of the misunderstanding that might have been with regards to the situation in South Africa and the science. I will try to go as quickly as I can, and at the same time making sure that we are able to clarify the nuances. So I'm going to start right away with the model for nicotine addiction. Like any other disease, nicotine addiction, as ICD, International Classification of Disease 10, recognizes this as a disease, and DSM-5, it's a chronic relapsing condition. And I think it's very important when we're having this conversation to understand the relapsing nature and the chronicity of the condition called nicotine addiction. So to put this simply, just like malaria, if we want to control malaria, we have to understand what causes malaria, which is the agent, parasites, and of course the agent needs to bite somebody, which is the host. And of course, the agent cannot get to the host without the vector, which is the mosquito. And the mosquito would not be able to breed in an environment that is not conducive. So mosquitoes, you find them in swamps, dirty areas, and that's the environment. The same thing for tobacco control. We will never be able to have good and strong tobacco control or ability to control nicotine addiction if we do not understand tobacco and nicotine products. And of course, support smokers, as we heard earlier on. They are a victim of the vector and not the cause. So the vector is very important, which is the tobacco industry and the vaping industry. And of course, the environment that controls that, the culture, denormalization, the old policy, the economic implication, and the history. The history matters, and this is why snus in Sweden cannot be compared to anywhere else. And I'm going to show you the failed attempt in the past to try to take snus elsewhere. So here we are. And maybe it's just to mention, this is why, just clarify, when people see the name of our center, Tobacco Industry Monitoring and Policy Research, they think it's a tobacco industry. However, we are doing the holistic and transdisciplinary research to make sure that we do not miss out and we understand the importance of controlling mosquitoes when you're talking malaria control. So we have a blueprint based on research and science for many years. And we all know that tobacco has been with us and tobacco smoking as a behavior has been centuries. And so there's been a lot of research, and the research culminated in this WHO framework on tobacco control. I'm not going to spend time on this, but important to know that there are general obligations, and South Africa is a signatory to this framework. And important for a conversation and for tobacco control and our understanding of need to control the vector, is to prevent industry interference, Article 5.3. The other thing to mention now is the supply measures, in particular, illicit trade control. The protocol on elimination of illicit trade, separately negotiated protocol. And that's for the reason separately negotiated, we'd also advocate that South Africa should actually sign this protocol to ensure that we implement track and trace, because we do have a problem of illicit cigarettes. Importantly, though, is to understand and accept that the WHO FCTC has been very effective, and the science behind it has been very effective. It does not matter any part of the world. So it's not any foreign intervention. The effort for South Africa to actually include the provisions of the or the recommendations of WHO as according to the FCTC is nothing foreign, but it's an intervention that works. In fact, South Africa had some of these interventions even before WHO put them into the FCTC. And many of the research and evidence that informed the protocol or the treaty was actually conducted in South Africa. One thing you can see from here is that since 2000, there's been decrease, and including in Sub-Saharan Africa. Sub-Saharan Africa has the lowest currently and has always had. And this is why the tobacco industry is very interested in Africa, and particularly in South Africa, because they know the projection, the demographic dividend is going to come to Africa, where it's been projected by 2050, Africa will have the largest population of those 15 and 24. Now, to just remove some of the confusion about examples that has been used in different parts of the world. UK, New Zealand is often mentioned. As you can see, the graph from the source, the WHO Global Tobacco Use Database, UK has moved from, in the last 20 years, from about 37 down to 15 as of 2020, but there are many countries in Africa and Latin America that have done even better. And the lung cancer rates in many of these countries are even much lower. So we should be very careful which countries we are actually copying. Now, to further demonstrate this is 2021 smoking rates. It's quite sad as I listen to many of our colleagues from the developed world sometimes saying Sweden is the only country in the world that has less than 5%, in short, ignoring that Africa exists. There are a dozen countries in Africa that have less than 5%. There are another 20 countries with less than 10%. So we have many countries in Africa to look at what they have done. Like I showed you earlier on, Senegal, Gabon, Uganda, they all had smoking prevalence the same as South Africa 20 years ago, but now they have daily smoking. Unfortunately, the sad reality that South Africa now has the highest rate of daily smoking in Africa. So let's get closer to what's been happening in South Africa for the last 40 years. I've been able to put together this data for 40 years. Since 1980, we all had this situation. Smoking was increasing rapidly. 1983 was the first World No Tobacco Day in South Africa, published in SAMJ. And you can see the peak in terms of smoking rates. And of course, by 1993, we passed the forced legislation. You can see the dramatic drop. In 1999 amendment, further drop. In 2020, 2007, 2008, significant drop. So it tells us that South Africa can do it. It does work. Unfortunately, come 2010, 2012, we started seeing no difference. Significantly, a small increase, but statistically not significant. And of course, until 2021, we started seeing a sharp turn. The same time vaping was introduced into South Africa, about 2011. Same time, we started seeing Hobley. We started seeing more roll your own, and I'm going to go closer to what has been happening around that time. But before I do that, I need to just clear something. no evidence that illicit consumption, as you can see, that blue graph is illicit trade, which started really increasing in 2010. It is not correlated to unemployment. There's no correlation. When we had all the decrease, for those 20 years before that time, there was no unemployment because tobacco use was coming down, because we had passed legislation. So there's no relationship. Similarly, despite the increase in illicit trade, cigarette smoking, and I mean cigarette, not smoking tobacco, because we have been confusing tobacco smoking with cigarette, with obli, with cigar, and I'm going to separate them. Cigarette smoking had not increased. 80% of illicit cigarettes are actually manufactured in South Africa. And that makes it very different from other countries where illicit is usually counterfeit. And therefore, we do not have the issue of plain packaging making things worse or better. It cannot get any worse because the same people who are producing your brand pack right now are the one producing this illicit. Illicit cigarettes or tax not paid do not kill you differently from cigarettes that taxes are paid for. So I think it's also important to recognize that. Illicit has not changed cigarette smoking, and illicit is about cigarette smoking. However, it has not helped us to reduce. So what could be happening? Our studies published in SAMJ last year by Carly and myself showed clearly that 50% of the increase we are seeing in tobacco smoking could be attributed to water pipe smoking. And roll your own, that is the Zolin. As you can see, we've been able to produce the trend analysis for snuff. E-cigarette phenomenally increased from 2010 to 2014, from 0.4 to 7.7. Unfortunately, total smoking has also increased from 18 to current levels of 33.9. 200% increase in e-cigarette, 200% increase in water pipe smoking, 50% increase overall tobacco smoking, 55 million more people, 5 million of the 14 million smokers are receiving social relief grant. It's a lot of money that government is burning. So when you plot a graph of cigarette smoking against tobacco smoking in South Africa, you can see you get different lines. The red line is what tobacco smoking is about. The blue line is cigarette smoking. You can see it's getting bigger and bigger and the gap. So it's cigarette, roll your own when you talk about tobacco smoking. So it is very important that we recognize that. And unfortunately, that may be causing some of the overestimation of the illicit because sometimes they are not smoking cigarette, but they're actually water pipe when people use the survey to measure it. Again, the sad reality now is the increase that we're seeing is mostly in Black African population, and to some extent, the colored, those who self-identify as colored, not so much in the Indian population or not so much in those who self-identify as white. That is a disaster in the making. And this is the reason why some of us do not sleep and wonder why we are talking about this bill, why people are dying. We are creating vulnerable population. And at the same time, we also see this is the same group that are taking up the vaping. So we have no harm reduction in South Africa. We have harm enhancement in South Africa. So on the left is the cigarette, and on the right is water pipe. You can see the big increase in water pipe smoking, both in Black African population and colored. And most of this are those that are age 16 and 24. And that's the sad reality. This bill needs to protect the next generation. South Africa is different from Sweden and all the other countries. It's a very youthful population. Almost 40% are aged younger than 35. And there's no, between 15 and 35, and there's no other way we can actually compare the two countries. This bill has to focus on youth prevention. Yes, I have spent 13 years out of my career in the last 25 years in tobacco control, helping people who were smoking. Let's talk quickly about single stick purchase. It is also an aspect that I've been quite interested in. As you can see, we've been tracking this since 2010. The last time we did the measurement about how people purchase, you can see that about almost 50% purchase their cigarette as loose draws. 63% of those are 18 to 24. So it actually tells you, actually it's 16 to 24, most of those who purchase loose draw are the young ones, 3 times more likely than the older ones. They're more likely to be Black Africans. They're more likely to live in rural area or informal settlements, and they're more likely to have made failed quit attempts. When you're trying to quit and you easily have access, it is much more difficult. So we should have this at the back of our mind when we're looking at regulation. Moving to harm reduction, there are a few assumptions for harm reduction that we need to be clear about. The assumption is that all smokers are aware and are concerned about their health and therefore willing to switch, which is not true. We've also done that. We've spoken to South Africans. We have measured in our previous study, we looked at online population about 12,000 South Africans. In our recent study with HSRC, we looked at over 3,000 South Africans, asked the smokers, if you know this was 99% safer, would you switch? And I'm going to show you some of the data now and what that means for this. So all the provisions in this bill has been supported by data in South Africa, in my view. The second assumption is a large percentage of those who are hardened smokers, or that we have a large percentage of those who are hardened smokers, unwilling and unable. Our studies have shown that, and we've published that, it's just about 6% of the population that you can classify as hardened. That is, never made a quit attempt, don't want to, and they're unwilling. The third is that those who attempt to quit using e-cigarette will be successful. Again, our studies have shown in 2021, looking at a survey of 18,000 South African, over 5,000 smokers, those who used e-cigarettes were more likely to relapse after 12 months. We also saw that those who used e-cigarettes were more likely to quit for 6 months, 12 months, but after 12 months, they were more likely to relapse. And finally, the last assumption is that there's a minimal unintended consequence at the population level. There's no doubt e-cigarette will give you less exposure to toxin than smoking. But the total population impact is what matters when you're looking at public health. So I'm not surprised when oncologists focus on individuals. I'm not surprised when clinicians, but as public health specialists and as a bill, as a policy for South Africa, it has to look at the whole population level impact. Would it have an effect on non-smoking youth initiation? Would tobacco industry have an access to start, normalizing all the effort that we've made in tobacco control for the last couple of years? And the answer is yes, and we have evidence to that. This part of the evidence, these are all packaged, as I'm not going to spend a lot of time, because you've seen all of these flavorings and the packages. If they are not regulated, it is a problem. I have done toxicology risk assessment. As you can see from that paper, I spent a year at the Harper School of Public Health, and my focus was looking at toxicological risk assessment methodology, and I applied this for the first time to smokeless tobacco. And I see the industry have used some of this recently, and I can tell you the limitation, the problems that those who have come here to tell you about cancer potency and relative risk and 95% safer, I actually do not understand the principle behind it. So I can just tell you, we did discover that other than NRTs, none of the product that we assessed had met the US EDP requirement of cancer risk. That is 1 in a 1 million chance in your lifetime that you're going to get cancer. So based on that, we say once you do not meet that, there must be that warning that this may cause cancer. That's what the protocol is. What we are having a conversation about today is not the first time. We had this early in 2000 when I also was involved with harm reduction debate. This was South Africa. They actually brought a lot of this product to South Africa. You can see cross-branding with Peter Stuyvesant, but it failed. And I published this paper in 2012, this is about 15 years ago already, on what harm reduction is about, why it will fail, why it will work. And this is not harm reduction. They were marketing this for dual use, as you can see there. That means you can use your cigarette and you can use your smokeless tobacco, your oral pouch or oral snus at that point. It is important to draw from the past. This is one of the tobacco secret documents paper that we wrote in 2009. And I will just quote from the tobacco industry document themselves. They say there is need to clearly position the product as a situational substitute. They know is not going to replace. Situational substitute for cigarettes rather than a replacement. So, honorable members, this has happened before with snus. I do not want South Africa to be caught in this again. We're moving. What is currently happening? It's all about marketing. The picture on the left is South Africa. These are young South Africans that have been used to market cigarettes at a place where the vaping was sponsoring Cotton First. This is a youth festival. This cannot be allowed to continue while we are having this debate. We now have over 3 million young South Africans, mostly, that are now vaping. We have 14 million South Africans that are smoking, destined to die. Why should we continue to wait when we already know the harm reduction has failed? 15 years of experiment in South Africa for harm reduction failed. We do not have the same that we have in Sweden. The other problem is that they can now vape with cannabis. Luckily, the new Cannabis Act, and that's why you have to make sure that this is consistent with an act that has already been passed by President last year. You cannot vape in public. You cannot vape cannabis in public, so it will be absurd that you can now vape nicotine because you're going to cause confusion in legislation. This is what you get. A lot of fruits, disposables. Most of these are sold in areas that are close to where young people are. So we're not surprised that we're getting more young people that are using. That's what our data is showing. There's a picture in Western Cape. You can see Cape Town, Kalecha, Mitchell's Plain. You have a lot of smokers, but there are no vape shops. Vape shops are the red points, and the green points are your colleges and higher education institution. If harm reduction were to work, it would cause so much disparity in success and cessation, and that's a problem. Again, what we are seeing is an increase of number of e-cigarette users who have never smoked before, particularly in the age of 16 to 34. 32% of e-cigarette users have never smoked before. They do not smoke. It has increased from 14 to 32%. Most of them using fruit flavor, and most of them less likely to have made a quit attempt. This is sales data. You can see that e-cigarettes has been increasing phenomenally until March 2024, after the second introduction of the excise tax. Thank God for that. However, unfortunately, disposable e-cigarettes did not reduce. They actually increased by 169%. Disposable, while the pot system or the refillables were decreasing and refills also increasing. The same thing for heated tobacco. We are seeing an increase, but with the second introduction of excise, it is actually coming down. So this is the picture. We are not seeing harm reduction. All the picture that you've been seeing earlier, where smoking goes up, vaping goes up, smoking comes down. We are seeing a parallel increase, and this is in the 16 to 24-year-old, where we were hoping that they can stop smoking the most, so that for a longer time, they have less likelihood to develop cancer and disease. Quickly, I'm going to speak to the evidence, because everybody's been talking about Cochrane. Cochrane review, great, strong evidence. However, you have to look at it closely. As you can see, out of the 90 studies screened, only 7 were used. And out of the 7, only 3 of them, actually 2, show statistical significance. What e-cigarettes are we talking about here in 2019? Are we talking about freebase, nicotine salt? Because these are 2 different things. Nicotine salt, by the way, you don't have to put flavors in them because of their nicotine salt. And most of the time, we currently have nicotine salt. The other problem with this data is, are we recommending 20 milligram, 30 milligram? They don't tell you which one is one that was used that was effective. What we actually need to be looking at is other pharmacological means that are controlled by SAPRA. Head-to-head comparison, Cochrane, shows that NRT is as effective as e-cigarette or varenicline or the combination. And it is important, the combination of NRT is what we use in clinical guidelines, not the single one that were used to compare. with e-cigarettes in the previous Cochrane review. We've also shown, as I said earlier on, that e-cigarettes also helps people for 6 months, 12 months. After that, they're more likely to relapse than those who did not use e-cigarettes. They develop more dependence and they have reduced quit intention. But in general, to conclude, this umbrella systematic review is more important. Young never smokers who use e-cigarettes are more likely than people who do not to initiate cigarette smoking. Use of free base nicotine e-cigarettes with clinical support is more efficacious than assisting smoking cessation than nicotine replacement. We do not know, however, if there is no clinical support, as we currently have it as a consumable good where anybody can buy it, that it can actually be effective. There's also no study to show nicotine salt products can actually be effective. This is the data of South Africans. I said it earlier on, never smokers. There are now 803,000 of them who are using vapes. For current smokers, there are 2.3 million who are using vapes. Former smokers, there are about 188,000 who are using vapes. They've stopped smoking, but they're using vapes. And there are 177,000 of them who are also still smoking, or who are using other type of tobacco product other than cigarette. What is important is that only 23% of those who said they cannot quit, they said they are willing to switch. And that, if you compare that to nicotine replacement therapy, you may get an additional 100,000 people be more successful. That is less than the risk that you pose to never smokers, this almost 1 million never smokers. And therefore, on a balance for public health, it's not a good idea to just let vaping uncontrolled. Importantly, is to protect these never smokers and the youth. This bill does not ban vaping. It allows smokers to still be able to use if they want to use them to quit. On issue of harm reduction, harm is a function of the number of people exposed as well. And that's what we have said earlier on. Currently, because of time, I will not be able to have a lot to discuss about the potential and the understanding of what we call vape. It is just not nicotine. It has propylene glycol and the VGs, which actually changes as you smoke, by the way. The ratio matters in this toxicity. So we have to know which e-cigarettes are we actually talking about. And this is the reason why you need to regulate the product. And the powers given to MISA is appropriate. As we begin to understand better, the regulation may change. I think we are second guessing what the minister is going to do with regulation. And I must say there's enough differentiation in this bill. If you look at the advertising provision, it says minister must when it talks to tobacco products. When it talks to e-cigarettes, it says the minister may do something. So it allows that issue. It has not been frozen. It allows for the precautionary principle and evolve in size. The diagram on the left tells you when you wrap up the amps in an open system for e-cigarette, you heat up and increase the temperature, you actually produce more toxins that become even more dangerous. So we have to understand it.
You have a last minute to be on the platform. Last minute.
Thank you very much. I would also quickly talk to TB because we have a big TB problem. The UCT study on the right side clearly shows us that even without tobacco smoke condensate, you can reduce the ability of the immune system to fight TB infection in your lungs. We've also been able to show that snuff, which does not have combustion, increases high blood pressure. This is South African studies. Even Philip Morris in this nicotine fact sheet clearly identifies that nicotine is addictive, not risk-free. It's highly toxic when ingested, and nicotine can cause increase in person's heart rate and blood pressure. This is tobacco industry themselves. They know the fact. This paper tells us about how dangerous nicotine is in nicotine pouch for somebody who came to ER using high levels of nicotine. For this reason, we have youth problem. The UK has taken action, and we have to make sure we don't follow the same problem. Quickly, heated tobacco. When we talk about toxins, they're not the same. So I'd like to say thank you, and my conclusion, I leave it with you, and you have my slides. Thank you very much.
Okay, thank you very much. Thank you for the presentation. Okay, yeah, I was still waiting, but I'm sure it will come in our discussion that what do you do with seasoned smokers who have an interest to quit and they are not able to quit, but you have to give them something that they could keep on going, but that is not as bad as what they were on. Honorable members, let me get your comments. I've seen hands have come up starting. Please note your hand, colleagues, so that you follow one after the other. I'll give you numbers. The number, Dr. Letape is number 1. Dr. Carl Leroux, number 2. Honorable Kumalo, you are number 3. Honorable Sine, you are number 4. Honorable Mutubatse, you are number 5. I don't know how it happened. Honorable Michelle is number 6. So late. You used to be number 1 or 2. The flu is keeping you down. Honorable Chirampungo said number 7. Those are the hands I have so far. Any other hand that is coming up, or just shout if you want to be number 8? None. Let us do those hands one after the
Can I
other.
be number 8, Chair? Can I be number 8, Chair?
Honorable Kwekwe, number 8, after Honorable Chirampungose. Start Honorable Dr. Letape, and then once you are completed, other members will continue thereafter. Thank you very much.
Thank you, Chair, and thank you for the presentation, Prof. Just have a few questions. You say the bill should concentrate on youth prevention. But remember, the way I understand the FCTC, it's also to help people that are dying, the adult smokers that are dying. How do we accommodate so that we have a balanced document that does not just look at youth? It also looks at adults who are the ones that have tobacco-related diseases and are dying. The second question, you've shown a slide that shows never smokers that are vaping. Do you have any study? Because in South Africa, because of our segmentation, affluent communities will have access to vapes. Poor communities still have access to cigarettes. Do you have a comparative study about the percentage of never smokers that vape and the percentage of young entrants into smoking from poor communities, so that we could see whether there's a difference? The third issue is we talk about population studies. Do you have any information about what is happening at population level? Because other communities that have introduced other products, some of them have seen the overall prevalence of tobacco use coming down, like in the UK, like in Japan, like in New Zealand. You say we are not like Sweden, but I would also have said that as South Africa, we're not like Senegal or Uganda. We have a different population profile. We have a different social setup. We don't have an authoritarian government. People are more freer. So does that come into your decision making? You take that only 6% are hardened, and you then say that e-cigarette success are more likely to relapse. But at the end, you then inform us that NRT is as effective as e-cigarettes. Can you try and explain that? Because that's a bit confusing. Does that mean that the e-cigarette relapse rate and the NRT relapse rate in South Africa is the same? And if they are as effective as NRT, should we not be regulating them, given the fact that we don't supply NRT to the majority of the population? It's usually accessed on medical aid, and most of the population is not on medical aid. E-cigarettes, people are self-medicating. Would that be a benefit in terms of that? Then the last question.
No,
You're talking about
that was your last
ministers.
One. That was your last one. That was your
the
last
last one is
No,
ministers.
No.
Powers
That
to the
was your
minister
last
to
one.
regulate.
That was your last one.
We have
Next.
anybody can be a minister in this country.
Next.
They have the knowledge to
Next.
regulate.
Next one, please.
Thank you, Chair.
Dr. Leroux.
Thank you, Chairperson, and thank you very much for the presentation. Sorry, I'm just going to try and put my camera on. Keeps on going on. I have a few questions. I just had a few questions around the slides and some of the correlations that were drawn. I think for me, I see that you say that in South Africa we have had an increase in vaping, but we've also had an increase in smoking. And so you say because of that, it doesn't seem like the vaping is having a harm reduction effect. But I think it's somewhat misleading when we understand that one of the major reasons why we have this significant increase is that because our legal tobacco area grouping is getting smaller and smaller. And we know that in international areas, one of the big things that have decreased smoking is that cigarettes have cost more. But because cigarettes are so easily and so cheaply available in South Africa, we have not had that benefit of our legislation and our taxation or our excise duties seeing that go down. So we sort of have a perfect storm in South Africa. We have unregulated vaping, which I completely agree is problematic, and I think we all agree with you that there needs to be regulation around that. But there's also been and again, there's this differentiation between poor communities and rich communities, where poor communities have access to cigarettes and richer communities have access to vapes. But I think when it's sort of a perfect storm in South Africa, and I think that it is quite problematic that confounder has not been put into that graph. And I think that it's clear where there is good regulation and where there's good enforcement of cigarettes, that when vaping increases, cigarette use does go down. I do hear your point around snus in Sweden and that it didn't work in South Africa, but I think, as you say, it's a cultural thing. And I think it seems like vaping is a much more culturally acceptable form of nicotine replacement than snus. And I think that we do need to consider that. And I think that it is, I think that I do find it worrying that you do not consider the benefits and the clear benefits of harm reduction that we've seen in so many other countries. So I just wanted to have your comment on the major confounder of illicit trade in that graph that you gave us. The second thing is I think it would be helpful to see the graphs of the countries that you spoke about in Africa where there has been a decrease, because it's obviously very important to see what the baseline of those countries was and how far they went down. And then I guess the third question for me is that you said at the beginning that there's that this legislation is going to create major improvement. I would like to know what aspects of the legislation. I think we have already got quite good and quite strict legislation. I can understand that there's going to be benefits in preventing, particularly on the vaping side of things, but I'm not quite sure what aspects you think will. I mean, our big issue is tobacco smoking, and from several people, we've heard concerns that this is going to drive people towards the illicit market, which is cheaper, and so that actually they believe that that there will be an increase in smoking if we basically put so many restrictions on the legal market. Now, I'd like your comment on which aspects do you think will have this dramatic effect on smoking, particularly,
Thank you.
and how we
Thank
will.
you.
Thank you very much.
Thank you very much. Next.
Thank you very much, Chair. Prof, let me take this opportunity to welcome your presentation, but I'm just having one clarity-seeking question that I want to pose. Prof, in this committee, we've been told several times that nicotine is not toxic. And some even say it does not cause any health problems, and hence oral pouch is as safe as medicinal nicotine replacement therapy. Then my issue, Chair, is that do you think, Professor, nicotine can cause health problems? If so, how best do you think these nicotine products should be regulated? Thank you very much, Chair.
Thank you, Chairperson. Greetings to everyone on the platform. Prof, it looks like many more people are smoking and vaping since 2018. when the department started with this bill. Should the industry be allowed to continue to market vapes the way they are marketing them while we are still here debating the bill? Do you think that if the current marketing continues, will we have even more vapes? And then number 2, from slide 13 and 14, it looks like the young Black Africans are the ones experiencing the most increase in smoking and are the ones buying cigarettes as loose straws. Do you think the tobacco industry is targeting Black Africans? And do you think this bill will help to prevent these very disappointing trends of Blacks likely to bear the cost of illness associated with smoking? Thank you, Chair.
No, thanks very much, Chair. Thanks, Prof. Just as an introduction, I was intrigued by your website. I see it's University of Pretoria and other flags that are Western and no South African flag, just as an opening. Tell me, what is your relation with the Bloomberg Foundation? And is heated tobacco products in South Africa more harmful than HTP in Japan? As a scholar, you have published in leading journals. Could you provide the committee with examples of your own tobacco work published on tobacco control in South Africa? Of this, approximately, how many have undergone peer review, formal peer review? In your professional opinion, is there a material difference between a research study, clinical research, and study and survey? Which of these methodologies would you regard as most robust and reliable for informing public policy, and why, as you have made those presentations? Now, on the last one, you are appointed as a leading expert in government delegation at NETLEC. What is your position on harm is harm, going back to the previous input that was done by the Prof? I think also going back to whether these stands have been peer-reviewed in your publications that you might want to share with us, as I asked earlier. Which specific scientific evidence or peer-reviewed studies do you rely on, substantiate on this position of harm and harm? Thanks.
Thank you, Prof, for your presentation. Many questions have already been asked, and in view of time, I'm just going to ask 3 short questions. As a point of clarity, how effective are vapes and other ends in helping people to quit smoking cigarettes? What is your view on the Cochrane report? Are you aware of any current research into the effects of secondhand vaping, and what are those findings? The rest has been asked by Dr. Leroux. Thank you.
Thank you so much, Chairperson, and thank you to the University of Pretoria for their presentation. My name is Alichiro from the EFF, Surambungwasa from the EFF. My question is on whether if this bill is enough, especially noting how vaping in particular is cited as something that leads young people especially into addiction, right? And not just into smoking, but other forms of addiction. And there have been studies as well, but particularly in urban areas like Johannesburg and Cape Town, that looked at the appeal of vaping amongst youth that is influenced by globalized pop culture and social media, and that it increases the risk of early nicotine addiction. And there's also been links that have been made to show that the marketing tools or the marketing robustness of vaping in Black townships in particular, in marginalized groups, are similar to the marketing tactics that were used during apartheid, on thriving addiction, alcohol use, and different substance abuse. And now, noting all of this information, there's various other studies that show that vaping is a real problem. I want to find out from the prof if this bill in particular is sufficient to counter that narrative. Thank you so much.
Thank you very much, Chairperson. Thank you very much, Professor, for your presentation and also for the support to the bill. I just wanted to reflect on what you have just said about those that have never smoked but have shown interest or have started with vaping. I have observed that even myself, I agree with you regarding that. I also take note of your suggestion where you say there may be a problem around the words used, the must regarding the minister's regulations, the must on regarding cigarettes, and the may, which is in the bill regarding vaping. I take note of that. Going back to your presentation, there is somewhere where you are making a comparison, which I was interested in. The comparison in the daily smoking rate. There is also data for 2024 where I had an interest. You are making mention of the 12 countries in Africa, but where I am discouraged, I am encouraged by the 5% and also those that are below 10%. I am discouraged when South Africa is at its highest in the daily smoking rate. What discourages me more are those that are against the introduction of this bill, because we want to be amongst those 12 countries that you have mentioned. Also, I would like to have your view where we can draw lessons or some experience as South Africans. Must we draw lessons from the low income, middle income, or the high income European countries, as previously suggested by previous speakers that presented in front of us? I think most of what you presented is food for thought to this portfolio committee. We take note. I think I will go back to your presentation and read it, because you sometimes talked to the presentation, so I will have to do up final touches. But I thank you for the presentation, Prof. Thank you very much, Chairperson.
This time around, Honorable Taiko jumped Honorable Mare. Or was Honorable Mare's hand not up?
Chair.
Honorable Mare, come through.
Thank you so much, Chairperson. Chairperson, you know, as long as we are in this portfolio and listening to all the different views, the only thing that we can come to mind is that everyone is saying that this thing is harmful, and we are saying harm is harm, and they are saying no, that these vapes is less harmful. So we have to think about this thing very clearly. And I think the way that they have spoken, the previous person also said that we are on the high rate of the smokers. I think we need to implement this bill as soon as possible, because we are going to have a lot of people that is having different types of sickness. But it's very eye-opening to listen to all these things, Chairperson, because I'm not a smoker. I don't know what it is to smoke. I've never smoked in my life. So for me to listen to this thing is still mind-boggling. But in any case, thank you so very much, Chairperson, and thank you for this presentation, Chairperson.
Prof, in your presentation, oh, no, not in your presentation, the bill is not talking much or at all about the nicotine pouches. And then probably hence there's less to be said about any harm to be reduced, because if the mom were to be chewing that, I don't know how it is used, putting it on her mouth while driving, there's less harm to her children in the same car, and there would be this and that. So this part probably left out allows us to talk less about a smoker who is struggling to quit, but can be offered something more than just blowing the smoke into my face and into his lungs. Why do we have that component of South African citizens, which is a large number? Because I concur with you, the bill is really, really discouraging new entrants into this. But if you're not differentiating, you are likely not to see that there are people who could then be saved and have a longer life by being on something else and not on the other things. I would really love to hear your comments on that. You were supposed to get you to stop at 5:05, but we'll give you another 3 minutes more. So you just have another